Uh, Thank you, Dr. Jain sir, Dr. Goyal sir, for the warm welcome, and I only hope that I live up to expectations. So, pregnancy is a very labile kind of a period in woman's life, full of joy, yet full of unfathomed seas, as we may call it. And thyroid disorders are very, very common in pregnancy, possibly because we are now very aggressively checking for and monitoring the thyroid functions. Next, please. So, before we move on, we must first understand that it is the most common endocrine issue in pregnancy, even commoner than diabetes, and may affect up to around 2% of people. Pregnancy may modify thyroid course, thyroid may modify pregnancy course, so both have to be seen in the same perspective. And therefore, for an optimal pregnancy management or for a smooth sail during pregnancy, one must monitor the thyroid function very closely. Next, please. So, this is a cartoon which shows that hypothalamus secretes TRH. TRH makes pituitary secrete TSH. That makes the thyroid release T4 converted to T3, and the thyroid hormones then exert a negative feedback both on the pituitary and hypothalamus, and a delicate balance is maintained. Next. So I will be talking more in detail about hyperthyroidism because that is more of an enigma. But before that, one must understand that HCG, it actually mimics the function on the TSH receptor, so much so that it has about 70% of action. So, in high concentration, it will cause hyperthyroidism, which we'll be coming to later, like the cases of a hydroform mole or a twin pregnancy, so on and so forth. Next, please. So, these are the factors that you need to understand. First of all, transient rise in HCG in the first trimester stimulates TSH receptor, and therefore one may have a high T3, high T4, and a low TSH. Of these, low TSH is the most common, and high T3, T4 might or might not happen. Second, estrogen causes high thyroxine binding globulin, which means that the total T3 and total T4 may be falsely high in pregnancy, and therefore one must understand that in pregnancy it may rise up to 1.5 times the case of a non pregnant state. One must also understand that the fetus, for that moment, is a foreign body in the mother's womb, which means that the autoimmunity is suppressed as a natural phenomenon by the body. So, the the Graves' disease, for example, may be better in pregnancy as compared to a non pregnant state. The thyroid hormone is metabolized by placenta, so the requirement goes up. And also, increased urine iodine excretion also warrants that the iodine intake be increased in pregnancy. In that, 150 micrograms per day is the requirement. In pregnancy, one may require up to 250 mics as well. So, hypothyroidism, a state in which the thyroid functions less than it actually should. Next, please. The most common problem that I feel is mental retardation in a fetus whose mother has a very high TSH. This is such a pity that it is such a common cause, a preventable cause of retardation. But apart from this, of course, abortions can happen, as can anemia, gestational hypertension, particularly diastolic, preeclampsia, abruptio placentae, so on and so forth. But as I said, the neurological and the psychoneurological impairment is the one which is preventable, and the patient and the person should be aware. Next. So this is very simple. First, second, third trimester, Lower limits being zero point 0.1, zero point 0.2, zero point 0.3. The first trimester, upper limit 2.5, second 3, third again 3. Now, people ask whether 5 one should conceive or not, or 4.5. Well, the answer is that in the first trimester, it should be less than 2.5, which indirectly also means that once you conceive, the levels should be less than 2.5. However, if someone conceives accidentally and then, as a matter of screening, you find out a high TSH, no love lost there, you could possibly start thyroxine straight away, which I'll be coming to later. Next. So 2.5 to 10 is what we are talking about. A low FT4, obviously you have to treat. TSH more than 10, obviously you have to treat. And of course, if you have hypothyroxemia but a normal TSH, it might not warrant treatment. But as far as we are concerned, as far as the Indian Thyroid Society says, any overt or any subclinical hypothyroidism in the mother needs to be treated with thyroxine. Next. TSH monitoring, well, every month till 20th week, and then once between the 26th and 32nd. But again, the guidelines from the ITS suggest that it should be checked monthly during pregnancy without fail. Now, after delivery, since the weight is lost, so the requirement for thyroxine goes down. So you may stop or titrate thyroxine, but I generally do not stop it totally and keep on monitoring the thyroid. If it is diagnosed in the pregnancy for the first time, then reduce the dose by 30% immediately after delivery. And if the patient has been a hypothyroid patient and then conceives, then obviously you go to the pre-pregnancy doses. But I myself reduce by 25 mics at a time and keep on monitoring TSH every 6 to 8 weeks. Some authorities say 4 to 8, but I feel 6 to 8 is a better way of doing things. Next. So, what about screening? So, the ATS, American Thyroid Society, says need not screen all, but our guidelines say all patients should be screened first trimester, euthyroid, screen again in the second trimester, euthyroid, screen again in the third trimester, and you must treat all overt as well as covert or subclinical hypothyroidism. Next. So what about the targets? The targets less than 2.5 in first trimester, less than 3 in the second and third trimesters. But what if the patient has a positive antibody? Well, you should screen them throughout gestation, 2 to 3 monthly, because there is also a trial from Iran that patients who are euthyroid biochemically but have high antibody titers, they are more prone to abortion, and in them, usage of thyroxine, despite being in euthyroid range, can prevent abortion. And we know that most patients we see, the antibody titers are more than 1300. Most reports say that. So there may be some role of thyroxine, but then that is not in the guidelines, and that would depend on the individual choices. So someone with a thyroid disorder, antibody is positive, but has recurrent abortion, one may try thyroxine even in a biochemically euthyroid state. Next, please. So, whom to screen? Women over 30 years, women with a family history of autoimmune disease or autoimmune thyroid disease, women with symptoms of thyroid hypofunction like swelling and puffiness, like lethargy, cold intolerance, hair loss, women with infertility, because you know that subclinical hypothyroidism can have two or three things which can be a problem. Number one is irregular cycles. Number two, impaired ovulation. Number three, high prolactin. Number four, PCO like morphology. So, all of these can happen even with subclinical. So, women with infertility should be treated. Obviously, those who are on thyroxine, which means they are hypothyroid preconception, needless to say, they also should be screened. And women in iodine deficient areas. So, of course, now that the salt is being fortified, but there are certain areas in the Gangetic belt still, like the belts of the eastern UP, like Gonda, Basti, Barai, so on and so forth. They are the places where iodine may still be deficient, and they should be treated and uh, and monitored. Next. So again, slight repetition, but I think this will hammer the point home. Should every patient be treated? Well, TSH more than 10 should be treated. If levels are more than between 2.5 and 10, if there is a low thyroxine, they should be treated. FT4 is is required, not total T4, because as I said, total T4 may be high. So what happens now is that because of HCG, the levels may be around zero point zero 0.01 or zero point 0.2, and you have a high T4, it will only confuse people. So free T4, which does not depend upon the thyroid binding globulin or the thyroid binding prealbumin, is preferred to total T4 in pregnant patients. Next. So, as I said, isolated hypothyroxemia in the presence of a normal TSH may not warrant treatment. So, again, stating more than 10 treat, and if 2.5 to 10, they say if it's possible antibody treat, but I treat every patient who has more than four four in the first trimester, because there was one guideline that below 4 you may avoid, and then if antibodies are positive you treat and maintain the level below 2.5. So maintain below 2.5. There is a debate whether to treat at 2.5 or whether to wait till 4. I will not wait. I will start treatment, for I know that thyroxine does not have side effects. The only side effect that thyroxine has is benign intracranial hypertension, which fortunately I have not seen till date. Yes, there have been patients who have had headache after thyroxine, but then there is there's no papilledema and it's normal. So, thyroxine is safe for both the mother and the child. Dose 1.6 mics per kg, but I to a later graph wherein I will tell at what level you should start what dose, because 1.6 would be a slightly bigger dose. We know that in a non-pregnant state it is 1.7 to 2.6 mics per kg per day, but we hardly give those high dosages in our subset of patients. On a similar note, in pregnancy, 1.6 though is recommended, may be a higher dose. Now, T3 will bring TSH much lower and much more quickly than T4, but T3 is contraindicated in pregnancy because there are no safety trials till date. And therefore, levothyroxine sodium is the most common one, and it is the category A drug. So, as I said, if the patient already has a thyroid disease, 30% price from non-pregnant value, and if newly diagnosed, 1.6 or 1 to 2. But as I said, I will come to the absolute values in a few minutes. Next, please. So this is what I was talking about, that 2.5 to 5 start 50 mics, 5 to 8 start 75, and more than that start 100. Now, someone will say that starting such a high dose, you may actually compromise the cardiac function. No, you will not, because If the levels are very, very high to the tune of uh, PSH of 100 or 125 or those ranges or more than that, the myocardium becomes really flabby. And therefore, if you give suddenly, you may actually cause the congestive failure. But at levels of 5 or 8, where the myocardium is not much compromised, you could actually start with these doses. Also, in the first trimester, the circulation would not be as hyperdynamic as would be later. So, even with these dosage, you will not precipitate a congestive failure. Now, what about iodine? Well, as I said, that pregnancy you require increased thyroid hormone production, which means you require more iodine. Second, there is increased excretion. Again, you require more iodine. So, on the whole, the iodine requirement goes up, and you may require up to 250 micrograms of iodine as compared to the usual 150 micrograms or 150 parts per million. So, how to assess? Well, if the iodine excretion is less than 150 micrograms per liter, then it is said to be deficient, and 250 mics for pregnant and lactating women is what the WHO recommends. The sources being seafood, eggs, meat, but then today the salt is also being fortified, and that may also be a source of iodine next. Now, what is Wolff-Chaikoff effect? Well, high dose iodide actually may inhibit thyroid hormone release from the thyroid. So, supplements exceeding 5 to 11 micrograms daily should be avoided because of the risk of maternal and thereby fetal hypothyroidism. So, first of all, ITS says ideally preconception, but as soon as you confirm pregnancy, check for TSH. If it's normal, check every trimester. If you require supplementation, every 4 weeks or every month till you deliver. Iodine intake 250 micrograms per day. Target first trimester 0.1 to 2.5, second 0.2 to 3, third 0.3 to 3, and I invariably treat every patient with more than 2.5 antibody positive or negative, although they say that below 4 you might not treat if there is negative antibody, but nonetheless I treat. The second is recurrent miscarriages with normal thyroxine levels with high anti-TPO. Thyroxine supplementation may help. Next. Now, hyperthyroidism and thyrotoxicosis are two different terms. Hyperthyroidism means when the gland is overfunctioning, and thyrotoxicosis simply means that the levels of T3 and T4 are high in the blood. So, hyperthyroidism is a type of thyrotoxicosis. Next, please. So, syndrome of hypermetabolism and hyperactivity. When the serum concentrations of T3, T4 are high, the thyroid gland may be hyperfunctioning or not. Next. So, Graves' disease is the most common cause of hyperthyroidism, other being the MNG, the STN, factitious, struma overi, and of course, not to forget the transient gestational thyrotoxicosis. Next. So it is physiological, wherein the HCG levels they exacerbate or accelerate the thyroid hormone production. Generally happens at levels of more than 1 lakh to 2 lakh units per liter, which means they are common in twin pregnancy or multiple gestational sacs. Next, it is generally self-limited. Antithyroid drugs are best avoided in this situation. Rarely you may use PTU, but one must understand that PTU has fallen into disrepute because of sometimes a fulminant and a permanent hepatic failure, and therefore it is now only recommended in the first trimester of pregnancy. Now, the way to distinguish an overproduction from the thyroid or the over function of thyroid is either by a nuclear scan or by the TSH antibody test. Nuclear scan is an absolute contraindication in pregnancy. So, obviously, we are only left with the TSH receptor antibody or the TRAB, as we may call it. And TRAB also may have a few ramifications. Next. So people may have iterative rate of GTT. I think that is just for academic use. But these people, because of the activity, may also have hyperthyroidism at normal HCG levels. This also holds true for non-pregnant patients who have abnormal responses to TRAB antibodies. So, uh, abnormal responses, which means accelerated binding and more efficacy, can actually cause. Next. So, seen in about 0.2%, which means far, far less common than hypothyroidism. Lower incidence because, as I said, autoimmunity is suppressed during the pregnant state because the body wants to protect the fetus, which for some time is foreign to its own body. Also, thyrotoxicosis may cause increased pregnancy loss and other complications, reduced fertility. So, actually, people with hyperthyroidism may conceive but may not even last for a couple of months, which means that the pregnancy may go undiagnosed before the miscarriage happens. Next. So the autoimmune levels go down, which actually means that the antibody levels go down. However, after postpartum, there is a rapid increase in autoantibody, and therefore one may see a high TSH in cases of hypothyroidism or an exacerbation of Graves' disease. Next. So, assays in pregnancy are important in the sense that if the TSH receptor antibody levels are more than 3 times the upper limit, then the fetal Graves' disease might happen. Hyperfunctioning thyroid. This may also cause goiter in the fetus, which may actually warrant uh, cesarean section because normal delivery might not be possible. Next. So, which are the women who do not suppress antibodies in pregnancy? Number one, with more severe, those with Graves' disease, those with infiltrative dermopathy, and obviously the fetus in these patients as high risk for thyrotoxicosis. So the mother will need antithyroid treatment, and as I said, PTU in the first trimester and and the carbimazole in the second or third trimester, carbimazole or methimazole. It's the same thing, just that methimazole is the active metabolite. So 5 mg of carbimazole is equivalent to 3 milligrams of methimazole. Next. So differential to the Graves is gestational transient thyrotoxicosis, and Graves is more severe, and MNGs and STNs are not very common in this age group, and even if they are, then the thyrotoxicosis caused by these is less severe than Graves' disease. Next. So this is important, and I think this is the crux of thyrotoxicosis. So obviously, Graves' disease is generally present before pregnancy. In pregnancy, the symptoms of Graves' disease may go down, or the thyrotoxicosis gestational may begin in pregnancy. Nausea, vomiting is commoner in the gestational thyrotoxicosis, and obviously goiter or ophthalmopathy or dermopathy is common in Graves' disease. Receptor antibodies obviously would be present in something which is autoimmune. So Graves, thyroid ultrasound will show an enlarged gland generally, but at least it will show increased vascularity, which will be normal. The vessel will be normal in gestational thyrotoxicosis. Next. So, pregnancy and hyperthyroidism, hyperdynamic circulation, hypermetabolism. In pregnancy, as I said, the levels of TBG are increased because of estrogen. So T4, T3 will be high. One must look at FT3 and FT4 both in cases of hypothyroidism and hyperthyroidism. And as I said earlier, also 1.5 times is the limit. Next. So, thyrotoxicosis, TSH below normal, chapter closed. Now, if T3 and T4 are normal, it is subclinical, and if the levels are above normal, then it is overt. Subclinical hyperthyroidism might not warrant anti-thyroid drugs. Antibodies confirm Graves' disease. Next. So, complications, well, recurrent pregnancy loss, preeclampsia, preterm delivery, hyperfunction of gland caused by TRAB. But yes, if the gland is overstimulated, it gives way. I mean, it cannot stand the stimulation further. It begins to hypofunction. But hypofunction is a very rare condition caused by TRAB antibodies. Now, fetal goiter. Fetal goiter can happen both with increased TRAB antibodies and anti-thyroid drugs. If given to the mother, they may cross the placenta. They reduce the gland function of the thyroid of the baby, which causes increased TSH and goiter. One must also understand that the thyroid gland of the baby starts to develop 12 to 13 weeks into gestation, and it gains the capacity to concentrate iodine at 18 to 19th week of gestation. Any and every situation which may cause decreased thyroxine in the baby may lead to decreased intellect, decreased IQ, and in severe cases, mental retardation. And as I said, it is the most common preventable cause in a child. Next. Treatment of choice, medical therapy, radioiodine, never, never, never. And because drugs can control things, but one must understand overtreatment has its own uh, issues. PTU and methimazole carry themselves across the placenta and therefore can cause goitrous hypothyroidism. So the fetal thyroid is subject to various factors, right from TRAB to the drugs, which can cause goiter and which can alter thyroid function. Next. So PTU has caused fulminant hepatic failure, and therefore it is only reserved for the first trimester. It's not that PTU doesn't have side effects to the fetus, it has, but they are far, far lesser than carbimazole or methimazole. So first trimester PTU, and subsequently, as soon as you cross the first trimester, prescribe carbimazole or methimazole. Next. So doses 30 to 450 milligrams of PTU in 3 doses because of the shorter half-life, or carbimazole 10 to 40, methimazole 5 to 30. The ratio uh, of uh, of PTU to carbimazole is 1 is to 10, rather 10 is to 1, and that of methimazole is around 16 to 20 is to 1. Next. So, aplasia cutis, omphalocele, esophageal atresia, choanal atresia, and of course, VSD are known. One may also have astigmatism with these patients. Next. So, PTU again mild cases of this have been described as regards aplasia cutis. TSH should monitor monthly in cases of hypothyroidism. In hyper, free T4, free T3, and TSH should be monitored. Next. So iodine is contraindicated. Beta blockers may cause IUGR, may cause fetal bradycardia. So they should be avoided. Next. Surgery. So when should surgery be done? Number one, uh, patients not responding to antithyroid drugs, and the period is second trimester is the safest, if at all, for the surgery to be done. Iodide maybe 7 to 10 days to reduce vascularity, but one must also understand the potential Wolff-Chaikoff effect and the fetal hypothyroxinemia, because mind you, 18 to 19 weeks is the time when the fetus begins to concentrate iodine. Also, because of a low thyroxine, the fetal thyroid may be stimulated, and withdrawal of antithyroid drugs may lead to fetal hyperthyroidism. So, surgery has to be done with great caution, even in second trimester, and it should not be ideally performed in the first or the third. Next. So, when do you operate? Well, intolerant, uncontrolled, if there is ignocytosis, which means unexplained fever and recurrent sore throat are the commonest symptoms. Malignancy obviously goes without saying that you have to operate, but then it's best to delay till postpartum. Next. So after delivery, antibodies rebound back and the Graves' disease may show exacerbation. Next. So transient postpartum thyrotoxicosis, well, because of the inflammation, there is leakage, as it were, of the hormones from the glands, and therefore this is followed by hypothyroidism, which is generally permanent. Next. So postpartum, we've seen that it may happen after delivery, and in these patients there is a decreased radioactive iodine uptake as compared to an increased in the Graves' disease. So decrease means that the gland is not overfunctioning; it's that the thyroiditis is causing the hormone to come out of the gland. Next, we'll skip this. So nursing, well, P2 and methimazole both come out in milk, but then the context of P2 now is not important because the only indication is first trimester of pregnancy, and up till 10 mg of neomerc or carbimazole uh, are allowed in the postpartum phase. Otherwise, there's a risk of the drug going to the child from the breast milk and may cause hypothyroidism. Next. So, Graves' disease versus GTT receptor antibodies test is the simplest and the most effective. PTU only in first trimester. Dosages I've discussed. Monthly monitoring of the entire thyroid profile. Surgery, if needs to be done, only to be done in the second trimester. I think that was my last slide. Thank you so much for bearing with such a long lecture, and I'll try my level best to answer questions if any.
Thank you, sir, for a wonderful lecture. Basically, you covered all the aspects of thyroid disorders in pregnancy. And as we know that there is a physiological change in thyroid hormones in pregnancy, so it was definitely a difficult topic, but you made it very, very easy. If anybody has any questions, then he can unmute himself and can directly ask his question with Dr. Dheeraj Kapoor. or they can put it in chat box. I'll ask those questions on behalf of you. So there is first question, sir. What is the effect of long term uh, thyroxine therapy on bone mineral density? At what dose should we start supplementing calcium?
This is a very pertinent question, and most people, rather most patients, ask this question. Now, what happens is that if you over replace thyroxine, the TSH goes down. That means the calcium is leached from the bone, as it were. So, if the levels are suppressed for long, for example, in hyperthyroidism or overcorrected hypothyroidism, there's a definite risk of osteoporosis. But even lifelong thyroxine, if you maintain TSH in the normal range, or if for some reason TSH is in the hypothyroid range also, the calcium will not be leached. That is one. But at the same time, one must understand that hypothyroidism, like most autoimmune diseases, is more common in women. And women, after they achieve their menopause, tend to lose calcium anyways. So if they are on thyroxine, they will lose calcium because they achieve menopause, not because of thyroxine. So one must start replacing calcium in the perimenopausal phase. Why? Because it is now known that sometimes increased FSH, this acts on the FSH receptors on the bone, and that causes osteoporosis. So FSH begins to rise in the perimenopausal phase, and that is the time you must begin to replace calcium, whether the patient is on thyroxine or not. The other is that calcium also inhibits the absorption of thyroxine. So you must give a gap of 3 to 4 hours between your calcium dose and the thyroxine. Thyroxine, we know, is generally taken empty stomach. So now, cutting the long story short, number one, thyroxine, if supplemented properly, normal TSH will not cause osteoporosis. Women from perimenopausal phase, whether hypothyroidism or not, require supplementation and gap of 3 to 4 hours between. The dose is 1.2 to 1.5 grams per day. So, two tablets of 500 milligrams, assuming that the patient is having at least a katori, a bowl of yogurt, or a glass doodh, 1 glass of milk, because 1 glass of milk contains just 300 milligrams of calcium. So, some milk and two tablets is what we are talking about.
Sir, although you have answered this question in your talk, but again, I would ask on behalf of Dr. Kamal Kishore, sir, is there any conversion formula while switching pregnant lady from PTO in first trimester to numericazole in second trimester?
Yeah, yeah, 10 is to 1 is what we are talking about. And if it is methimazole, then 16 to 20 is to 1.
Uh, Another question, when should we check TSH in neonate?
Okay. So this was actually pregnancy, but you know what? Immediately after delivery, there's a
Some called there.
surge. There's a surge in TSH, and on day one, it may be as high as 40 TSH. But cord blood is more representative, so you must check that. And if the levels are more than 6 or 7 after 2 or 3 days of delivery, start supplementation, and these levels may recover. So you keep on monitoring every 4 weeks, but you must not delay treatment in cases of high TSH. But one must understand that post delivery, for maybe a day or maybe 36 hours, they may be as high as 40.
There is a question from Dr. Ravindra Gupta. Is there any role of FT4 with TSH in management during pregnancy?
Absolutely, sir. There's the total role. Uh, so in pregnancy, as I said, we check all the three every time. T3, FT3, FT4, TSH, both in patients of hyper and hyper. But as I said, also if TSH is normal. Isolated hyperthyroxanemia carries no meaning, but if TSH is high and FT4 is low compared to someone with high TSH and normal FT4, the person with low FT4 will have more problems in fetus as compared to the one with high TSH and normal FT4. So there is always a role of FT4 in prognosticating as well as accelerating the treatment with more robust nature.
There is a question from Dr. Moksh. Sir, if someone has PCOD as well as hypothyroidism, what are the food items to be included in what are excluded in the diet?
Sweets, fat, and juices are only the three items that need to be excluded, nothing else. Now, I will go to Google. Now, what Google says is stop cabbage, stop cauliflower, stop broccoli, stop walnuts, stop lady's fingers, stop mustard. The logic is that brinjals, the logic is that these contain glucosinolates, which may actually impair the thyroid function. Now, that point is very well taken, but I don't think there is anyone in our community who eats a raw brinjal or a raw cauliflower or raw broccoli. The moment you heat them, the moment you saute them, the moment you boil them, you actually destroy the glucosinolates. So these things become absolutely edible even in patients with hypothyroidism. A word about soya bean. Soya bean also reduces absorption of thyroxine. So if someone loves soya bean, you should have a 3 to 4 hour gap between no soya intake and the thyroxine. PCOD, well, you know it's a disease of people who have a higher than the usual weight. So in them, obviously, any and everything which increases weight, the sweets, the fried, and the juices should be.
Uh, that's all in the chat box. If anybody has any other question, then please unmute yourself and ask.
Good evening, everyone. First of all, thank you, Dr. Kapoor, for a very, very clear presentation on thyroid disorders in pregnancy. And this is something we handle every day. And the point that I took from this was one point was that we need to look at the cord blood TSH, which we are not doing routinely. We are getting the baby's TSH done maybe on the fourth or fifth day. So that was one thing. And thank you for the excellent presentation. I also want to thank all the people listening in today. And lastly, I want, and but not the least, I want to thank Dr. Pavan Goyal for his indefatigable mission. That was the Tuesday academic fiesta, which he has unfailingly put up every Tuesday. Never mind the attendance, he went on, and many people have benefited by your endeavor. And for those who miss it, you have made an alternative. We can always look it up on the YouTube channel. And Dr. Mahavir Jain, our president, has ably supported him in this endeavor. And for the future, next year, that we are looking at whether we can get some credit points for this. So we are working on it. Thank you, everyone, and good night.